Welcome to the 19th meeting of the Standing Committee on Indigenous Affairs and of the North.
The unceded territory of the Algonquin Anishinaabe Nation. We have just a couple of housekeeping matters to take care of before we start the panels. The clerk distributed to everyone the budget for our fourth study. I would like to see if we have the committee's approval for this budget. How says the committee? Do we have approval? Okay, very good. So approved. Thank you very much. And a reminder that the first 12 witnesses for the study are due by noon this Friday, May the 13th. 6 witnesses for the Liberals, 4 for the Conservatives, 1 witness for the NDP, and that would be 1 witness for the Bloc as well, I guess, yes. And the rest of the witnesses list is due on noon on May the 20th. This is to give the clerk the ability to book witnesses in advance since we're coming up soon on the study after our May break week. Aujourd'hui, on continue notre troisième.
Today we continue our third study on the administration and access. I'm sorry, Mr. Chair. Mr. Chair, we had understood, I believe, we had understood that we had 2 witnesses each. So that's over 12. 6411. We're continuing our study on the administration and access of Indigenous peoples to the Non-Insured Health Benefit Program, NIHB.
Please, a few notes. Please wait until I recognize you by name before speaking. And if you are on the video conference, please click on the microphone icon to unmute yourself. Those in the room, your microphone will be controlled as normal by the preceding and verification officer. When speaking, please speak slowly and clearly. And when you are not speaking, your microphone should be on mute. A reminder that all comments should be addressed through the chair. So today's committee meeting is like all of the committee meetings. We will introduce our guests, and they will have 5 minutes each to speak, after which we'll proceed with a question period. I would like to introduce our 3 witnesses today. I shouldn't say Mr., maybe it's Miss Lee Thom. I haven't got it. Oh, it's Mr. Lee Thom, elected official of the Nikino Métis settlement. Secondly, Francis Chartrand, Minister of Health and Wellness of the Manitoba Métis Federation. Finally, third, Marge Friesen, Minister of Health, Métis Nation of Saskatchewan. And we also have with us Adele Panahi, Director Health, Métis Nation of Saskatchewan. So I would like to start the testimony from the witnesses, and we'll begin with Mr. Lee Thom. Mr. Lee Thom, you will have 5 minutes for your presentation.
Thank you, sir, and it's an honor to be here. I'll make this quick. I have some really good notes, and hopefully I can stay focused. Took me a while to get here, but I'm here. First of all, my name is Lee Thom, and I'm from the Kikino Métis settlement. Kikino is in northern Alberta. It is 2 hours north of Edmonton. And I'll give you a quick history on the settlements, and then I'll go into my 3 topics that I've elected to talk about today. The Métis settlements in 1990 were given a Métis settlement accord from the province of the day, and that gave 2 million acres of fee simple land, which brought us a land base. We were then given some funding to build our infrastructure and build our communities. And that was the accord. Through the accord ending at 11, there was a short interim funding, which led to 13, the LTA. And now we're at the end of the LTA. The LTA was put in and designed for us to continue our future funding, with Schedule J being one part of the LTA that was to give us beneficial ownership of mines and minerals, which didn't happen. long story short, and that's a very long story, I'm making it short here. In 2017, the Métis settlement signed an MOU with the federal government, Minister Bennett of the day, which a piece of that was to protect our lands through Section 35 rights. 2018 framework bought a framework agreement with a bunch of items, the main one being health. There's 10 of them, but I won't go through that. I'm cutting into my time here of my topics. Health being one of the most important ones. And health, right now, the Métis settlements are in discussion with the province and always have been about three main topics. One being senior services, mental health and addiction. Senior services, in our community, we have right now anywhere from 80 to 100 seniors living in our community now that have no access to dental, visual. A lot of barriers come up with transportation, education, training for our local workers and people to supply services. We're told as Métis settlements that the services are at arm's length. And the hope is that someday we can have facilities that can house the services that are so important to our communities as a small municipality will. I'm right off my notes now. I know what I'm talking about. I don't like to be scripted, so I'm just gonna continue as Lee Tom. Mental health and addictions are a big contributor to rural crime, seniors abuse, and problems that we have in our community now with youth, lacking participation, I guess, programs, funding for youth to access sports is huge, creating a campaign that's anti-drug and alcohol. I really think, that health ties to the home. Healthier homes, healthier people. I really believe that addressing mold in our communities and dealing with housing, inefficient housing in the days of climate change now and the movement towards energy efficiency, addressing inefficiency in our homes is a big impact on health. Our homes are inefficient. We are in dire need of funding that supports housing tied to health, funding that supports policing tied to reduction in rural crime, everything that comes with mental health and addictions, seniors abuse. There's so much we can talk about. I had my scripted notes, and I may have missed a few things here. As you can tell, I like to speak from my heart, and I like to come as a Métis person on a Métis settlement, and make the government understand that we signed two agreements in the past, and the 2018 framework agreement identified 10 things again. I want to make that point clear. And since then, we haven't had the traction that we would hope to have that would identify line item dollars for the Métis settlement specific. We tend to be budgeted as Métis communities, and there's a lot of Métis communities, but Alberta is unique to the only province that has land-based Métis, and the only province that has land-based Métis with infrastructure, with roads, with staff, administration, elected people. Good governance is a huge part of our system, and without good governance, programs that we offer to our members, such as 50-50 repair programs where people can access dollars to repair their homes, to gain medical travel. Some of the programs that we have in our communities are very important and very important to our members.
So, Mr. Tom, we're past the 5 minutes. If you could wrap up, please.
Yeah, okay, I'll wrap up quick. Sorry. I just really want, I think we need to follow the obligations that were set in the 2018 framework agreement that were identified, and we're on health today. I understand that. And I did give some things on health, and I think the signing with Minister Bennett was a day where there was supposed to be reconciliation from that time, and I haven't seen the traction. Being elected now, I haven't seen the movement, and I think that The federal budget needs to acknowledge the Métis settlements directly with flow-through funding to address all issues. Thank you very much, and it's an honor to be here. Thanks for your time.
Thank you, Mr. Tom. We'll now go to Frances Chartrand. Ms. Chartrand, you have 5 minutes.
Good afternoon, everyone. I'd like to thank you for allowing the Manitoba Métis Federation to speak here today. We are looking forward to this study on Indigenous peoples' access to the non-insured benefits program and are excited to start a conversation on improving the health of our Red River Métis citizens. Before I start the discussion, I would like to provide a few definitions and a little bit of information about our identity. The Manitoba Métis Federation is the Indigenous collective that was historically known as the Red River Métis. We are Canada's negotiating partners in Confederation and the founder of the great province of Manitoba. Our collective or community goes beyond borders, and our citizens are today located within what is now Manitoba, as well as elsewhere inside and outside of Canada. With our July 2021 Canada, Manitoba Self-Government Recognition and Implementation Agreement, the MMF is the federally recognized government of the Red River Métis, also known as the Manitoba Métis, a distinct Indigenous people whose rights are recognized and affirmed as protected by Section 35 of the Constitution Act 1982. The Manitoba Métis Federation has undertaken substantial health research based on samples over 70,000 of our citizens. While MMF citizens are not covered under non-insured health benefit, the 2010 Métis Atlas and subsequent studies have shown that the overall health and life expectancy of Métis is poorer when compared to the rest of Manitobans. Social determinants of health, including socioeconomic status and access to service factors, largely into this. The finding of our research indicates the rate of chronic illness is extremely high in our communities. Heart disease is 40% higher than the general Canadian population. Arthritis is 22% higher. Diabetes is 34% higher. And diabetes-related lower limbs amputation are 49% higher. In order to provide equitable and culturally appropriate services, Métis citizens in Manitoba require health and social programs, and services are developed and delivered by Métis citizens and Métis people. In 2017, a prescription drug program was developed by the Manitoba Métis Federation and introduced to assist Métis seniors and in need to ensure they were not out of pocket for medication expensive. To date, our prescription drug program has been funded slowly by the Manitoba Métis Federation, despite our attempts to work with Canada to develop a partnership. The PDP program covers a comprehensive range of prescription drugs and over-the-counter medications listed on the Manitoba Pharmacare formulary. In addition, a small range of medical supplies and equipment items are covered by the program. Presently, the PDP program covers and programs supports by you have to maintain a current and valid MMF citizenship card. You have to be 55 years and older. You have to have an annual income of $25,000 or less. You are enrolled in the Manitoba Pharmacare program and agree to use Medocare Pharmacy as their sole dispensary. The utilization rate of the program among eligible Métis seniors and older adults continues to rise. It has doubled from 2019 to 20 and to 2020-22 fiscal years. The program utilization is projected to climb as seniors are known to have a higher prevalence of certain chronic conditions compared to younger Canadians and lower incomes and pension plans. Unlike non-insured health benefits and medical coverage for First Nations individuals, the PDP does not cover diagnostic services such as examinations, radiographs, audiology services, preventative services, orthotics, dental, medical transportation, accommodation, to name a few. MMF is working on expanding the program to cover the stated above services to alleviate financial burdens on low-income Métis older adults. So there is a demand for more and more broader range of services, and we could work, the Métis can work complementary with Manitoba and Canada. The Manitoba Métis has the right to self-determination recognized in the United Nations Declaration on the Rights of Indigenous Peoples and the inherent right to self-government recognized and affirmed by Section 35. The right to self-determination includes the right to health in all its forms. The administration and delivery of healthcare services, setting our own priorities, administrating our own healthcare budgets, and managing our own resources. Provisions to negotiate agreements or provisions to promote the health, safety, and welfare of Métis citizens within a defined area of pharmaceutical and medical services, and to enhance access as needed.
So Ms. Chartrand, I'll have to ask you to wrap up. We're over 5 minutes too.
Okay. We are prepared to work with Canada at the technical level on the negotiation of agreements and participating in the development and promotion of health legislation that will ensure our elders and the vulnerable Métis citizens have the health services they require. Thank you very much for having me here to present today.
Thank you, Ms. Chartrand. We'll now go to our third witnesses. We have Marge Friesen and Adele Panahi. I'm not sure whether you're going to divide your time or just one speaker, but you have 5 minutes. Thank you.
Thank you. Tansé bonjour. Hello, everyone. Good afternoon, Chair and Committee, and thank you for providing us this opportunity to participate in your hearing today. I'm here as the Minister of Health with Métis Nation Saskatchewan to speak to you about non-insured health benefits for our Métis citizens, and they've identified it as a top health priority across our homeland. You've heard from our President, Métis National Council President Cassidy Caron recently, and I'd like to provide further details on health experiences that our people have experienced and want to specifically comment on the non-insured health benefits. Métis Nation Saskatchewan is one of the 4 governing members of the MNC, and we represent the Métis citizens in Saskatchewan, and our Métis Nation Legislative Assembly governs our people and also enacts legislation and regulations and the conduct of MNS. Our people have a holistic understanding of health shaped by larger social structures that include kinship ties, community, identity, and culture, and especially connections to the land. These principles are foundational to any work that addresses health inequities faced among Métis people. Colonization is an important social determinant of health that contributes to the health inequalities faced by Métis peoples to this day. Examples of colonial practices include residential schools, day schools, industrial schools. There's a large proportion of Métis children in care, which we'd like to address, and ongoing systemic racism in our healthcare institutions. In the last several years, MNS has carried out several engagement sessions across the province, across our 12 regions, and have reached out to over 800 citizens, and they have expressed top priority, which is non-insured health benefits, and like to see that come to fruition in the future. And this is some of the experiences I'd like to share with you today. Regarding affordability of healthcare and medication, many citizens cannot afford to prioritize their health. For example, citizens may choose between their basic needs, such as shelter and food, to pay for their medications and their prescriptions. And we've heard stories, too, across the homeland that some folks who are living on a fixed income, particularly elders and seniors in our communities, also in order for people to ensure that they're getting the medication or the prescriptions, they share prescriptions among their family members who take the same medication or other community members, neighbors, or friends. So this is quite alarming to us as healthcare advocates that we'd like to address. High food costs and costs for testing equipment, such as diabetic implements and equipment, are barriers to good health for Métis citizens. This barrier is especially concerning among, as I mentioned, our seniors and elders. There's an urgent need to support the cost of prescription medication for seniors and to prioritize home care and long-term care in our local communities. Oftentimes, our elders are shipped away because the long-term care facilities are outside their communities, which we know and learn from experience in listening to citizens that this is often the case, and then they lose contact with their families and their connection to the land and their community life as well. So that is a concern for us. We've also heard stories about cancer patients living hundreds of miles away from cancer centers who slept in their vehicles because they couldn't afford hotel accommodations after their treatment, and it's too far for them to go home when they're not feeling well after a cancer treatment. So that is concerning for us as well. It's very common for Métis families and communities to regularly host fundraisers to raise money so families can afford to stay in a hotel and to ensure that their needs are met when they're going through cancer treatments. During the pandemic, MNS started a medical travel assistance program to support the costs of fuel, food, and accommodations. And the requirement is high need, low income people who access that, who have medical appointments and access that program. Since July 2020, we've supported 965 citizens to attend almost 4,000 medical appointments, and the cost is just over $500,000. These numbers demonstrate the significant need for Métis-specific medical travel assistance, and yet the program does not have sustainable funding. The Northwest Territories is the only jurisdiction in Canada that sponsors non-insured health benefits for Métis citizens. The program is administered by Alberta Blue Cross, so it's an external service provider, and covers eligible prescription drugs, dental services, vision care, medical supplies and implements or equipment, as well as medical travel benefits. This program provides a successful model that MNS can implement across the Métis homeland in Saskatchewan in collaboration with the federal and provincial governments. MNS and other MNC
Ms. Friesen, I'll have to ask you to wrap up, please.
Thank you. Are ready and committed to develop a program and that is financially sustainable to meet the needs, the healthcare needs and priorities for Métis citizens. Thank you again for the opportunity to articulate the immediate health priority of MNS and express the voice of Métis citizens across Saskatchewan, and we welcome questions you may have. Merci.
Thank you, Minister. We'll now proceed to the questions. I believe Ms. Stubbs is first up, and you will have 6 minutes.
Thank you, Mr. Chair. Thanks to all the witnesses for being here today. I think probably all of us share this view that we just only wish we had more time to hear from you and also have question exchanges. I am just going to ask Lee some questions. He hails from my neck of the woods, and I just want to appreciate him pointing out the unique position of Métis settlements in Alberta. It's a point I'm trying to emphasize on behalf of Albertans repeatedly in this committee, indeed in part because 4 of the ABT settlements are in Lakeland. Lee, Minister Hajdu was here on Friday, and she said, quote, "We have begun to transfer funding for distinctions-based Métis-specific programming to Métis governments." Lee, you're an elected councillor of a Métis government in Kikino. And so I just want to clarify, has Kikino received any funding from the federal government, or has anyone from the federal government reached out to the settlement?
Yeah, I'd be glad to answer that. It's pretty straightforward. We do not get any funding in Alberta through other Métis affiliates. We are standalone and have been really advocating for our own voice to represent our own membership through our own governance and speak for ourselves, basically. But Shannon, the answer to your question is no, no, no. We've never received any federal funding for this program.
And can you give us any sense if federal public servants or anyone from the department or any of the government offices has reached out to your governance council and to the settlement to work on helping to deliver Métis settlement needs with regard to health insurance, but other services given the 2016 Daniels decision about the federal government's duties?
No, we've had no communication thus far. We've been trying to work on an agreement that would be tripartite with the province and the federal government, and to take care of some of the obligations as of the Daniels decision, where by Section 9124, the Métis people are now considered Indian as far as the Indian Act goes. And we've been advocating since that decision of 2013 to get those rights and to secure our land base and secure it in the Constitution of Canada and securing our Section 35 rights. So, Shannon, the long answer, there's a long and a short, but the short one will be, no, we've had no communication with the federal government. We need it, and we are ready for it. The settlements are open for business. And whether health is a business, housing is a business, and they're all businesses, because at the end of the day, they're all going to identify a line item in your federal budget that says Métis Settlements General Council. So,
yeah, thanks, Lee. I think probably all Canadians want to see actions and outcomes matched with words and promises. So I hope that work, that necessary work, gets going in cooperation with the Métis settlements. So can I just, Lee, get you to expand on the innovative ways and what your community has had to do in order to provide for yourselves and for your people? You and other witnesses certainly did point out all of the different aspects of health outcomes and health determinants. And so since you haven't received funding for services that other Indigenous communities get, like for vision, dental, mental health supports, medication and medical transportation, could you expand on what your community has put in place to get your community members treatments that they need?
Sure, I can expand for sure. Right now, we have an agreement with the province. We do our members have access to Alberta healthcare. These programs, like the program we're speaking of now, the insured health benefit, non-insured health benefit, we have never been offered or have access to. Right now, the province supports our community with an RN that's been here for 17 years with our community. That's a provincial support. But local, we are very, 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 innovative in taking care of our elders that need assistance. We have budget line items in our budget that support our elders with $1,100 annually to assist them with medications, medical transportation issues. And we also do, our community comes together very often for fundraisers. And I've heard another lady mention fundraisers in her speech there. And it's very key to understand that Métis people come together in a community that's largely, not largely, but somewhat, at the lower end of earnings, can come together and bring their dollars to the table to assist our members. That's another very innovative one. It's very touching to see that our community comes together to support through fundraising. But right now, in the budget that we have, the $1,100 per senior is a medical fund. And that's what we've been doing for now. But most of our programs, I guess, are provincially supplied right now. Nothing extra, nothing, I guess, on top of, including the program we're talking about now. Thank you.
Thank you.
Thank you, Ms. Stubbs. We'll now go to Mr. Pawlowski. Mr. Pawlowski, you have 6 minutes.
Direct my questions to Ms. Chartrand. But first a question. Now, the Manitoba Métis Federation, does that represent all Métis in Manitoba or just people that were part of the Red River Métis Association? And if you're Métis in Manitoba but not from the Red River Association, who represents them?
Thank you for the question. We're a Métis government. We're not association or department, and we represent all Métis that have ties to the Métis Red River as per our definition.
So I'm wondering specifically, I worked a few years in Norway House as a doctor in the hospital. As you know, there's the Norway House First Nations, but there's the Métis settlement right beside it. Do you represent them, or are they represented by some other body?
Yes, we represent them. In fact, our local chair there, his name is Lloyd Flett, and we have direct contact with him. And then we have 7 regions across the province of Manitoba, and Lloyd Flett is part of the Thompson region. So we represent all Métis citizens regardless where they live.
Very good. So I know Lloyd, actually. I remember him from back when I was there, so say hello to Lloyd.
Yes.
But I would certainly comment, and this will lead to a question, having worked there a couple of years in the hospital, and do I have this correct, that the people who happen to be from the Métis community, who in a lot of ways seem pretty similar to the people who lived on the First Nations community, they don't get the same benefit. They don't get the same travel arrangements. They don't get dental. They don't get their eyeglasses paid for, and they have to pay for all their medications because they're Métis, and everyone right next door in the First Nations community gets all that paid for, right?
Yes, in fact, I can answer that question. And no, we're not similar to First Nations. We have our own language, our own culture, and our own beliefs. So you are absolutely right regarding First Nation reserves and Métis communities. First Nations reserves get all the access to all the programming and health services. The Métis citizens have to travel hundreds of miles to go see a doctor. In fact, I come from a small community in central Manitoba. I live a mile from a First Nations community. And if I want to see a doctor, I drive right by the First Nations Health Hub and Health Center and have to travel 125 kilometers to go see a medical doctor. And when I think about health services and health programs, and you think of a lack of supports or lack of programming that we have across the province of Manitoba, you could tell by our research that the Manitoba Métis, Red River Métis citizens have no programs and services. In fact, the province of Manitoba, we get absolutely no funding or any support from the province of Manitoba for any programming that we do for our Métis citizens.
So now you quoted some statistics. You said the Métis population had a 40% higher incidence of coronary artery disease, 34% higher incidence of diabetes, 49% higher incidence of amputation. Is that compared to the is that compared to the Indigenous population, or presumably the whole population?
It's compared to the whole populations, and you probably know Dr. Judy Bartlett. She led the file, and she led the research when we did the Métis Atlas in 2010.
You know how that compares to the numbers for the First Nations communities? Is that worse or better or about the same?
Ours is worse. In fact, when we look at the research and you look at it, we have a shorter version on our line. It's comparable to everyone. And our heart disease and our diabetes and arthritis was higher than any, even First Nations and any citizens across the province of Manitoba.
Do you think that's a result in part because of the lack of non-insured health benefits and that you don't get the same quality of medical services as First Nations people?
Not only First Nations people, but I would say we don't get any health benefits compared to any citizens in the province of Manitoba and across Canada.
Okay, you mentioned the PDP program. What does PDP stand for?
The PDP program is a prescription drug program that was initiated by the Manitoba Métis Federation. So at our annual General Assembly, after we found out all the research and everything that came through, we asked our citizens across the province of Manitoba what we could do to help our elders and our seniors and the most vulnerable. And the direction they gave us was to go and find money and financial supports to help pay for their medication. You heard earlier with some of our colleagues that were presenting, they said that you're sharing medication. So when you look at the poverty and you look at the health of Métis grandparents that are raising their grandchildren, would you buy food for your grandchildren or would you pay for your medication? Would you pay your hydro bill or would you pay for your medication? And then you look at the information I shared earlier regarding Métis citizens die earlier than any citizen across the province of Manitoba.
And where does the funding for the PDP program come from?
We're presently working with the federal government to come up with a plan. However, all of the programming that we presently do is that the funding comes from our internal economic bills. And we're also looking at a tripartite solution where we work with the province and we work with the federal government and the Métis government.
Thank you. We'll now go to Madame Gill. Madame Gill, vous avez 6 minutes.
Merci, monsieur.
Thank you. I'd like to thank all the witnesses. We've heard many witnesses speak to the last sessions of the committee, and we often hear for the Métis, there's a constitutional issue. We hear about Section 35 and about provincial governments and the problems that you have. Mrs. Chartrand, you talked about the choice that people have to make between their health and essential needs, such as housing. And you also talked about equity. What are the reasons why, right now, this inequality exists? According to you, what are the reasons for the inequality? Thank you.
So, Ms. Chartrand, if you want to start off, and then we'll go to the other witnesses as well for comment.
I don't speak French, so I'd probably need some assistance regarding the question. I'd like to apologize now for that.
Not a problem. Did any of the witnesses get the translation? I'll turn to Ms. Friesen if you wish to comment.
Yes. Thank you, Marcy. Please. Yes, some of the inequalities between Indigenous peoples of Canada is access to health care. First Nations citizens have access to non-insured health benefits and preventative programming and screening. Métis citizens do not. Even though we are members of Indigenous peoples of Canada and we are under Section 35 of the Canadian Constitution, we do not have the same benefits as our First Nations relatives. So it causes a great deal of inequity with that, and geography is a large factor of how folks access services.
Je veux pas vous interrompre, je sais qu'on n'a pas beaucoup de...
I know we don't have a lot of time. So this is what I highlighted, but I'd like to know what explains this, because we're here to try to find solutions. So we have the principle that, yes, there is inequality, so what needs to be done? You talked about tripartite discussions with the provincial governments, but I'm wondering why this inequity persists. You should have quality health care. You should. Oftentimes the populations are very far from healthcare. So could you help us to understand what are the reasons why today there is still this inequality, in your opinion, of course?
Merci. Yes, I'd like to answer that. I think one of the major barriers is the discussion and the conversation and who is representing the Métis people of Canada. Our jurisdictions are very distinct, although we are collaborative. Métis peoples have never had this opportunity. With the National Accord on Health signed in 2017, the self-government agreement that Métis Nation signed in 2019 really distinguishes what it is that Métis citizens are lacking in Métis communities across the country. So we're looking here and specifically talking about non-insured health benefits because we would like to see equity for Métis citizens of Canada, Métis citizens of Saskatchewan who we represent, and across the country, so that people, as Ms. Chartrand, my Manitoba colleague, has stated, Métis citizens die earlier than other Canadians across the country because of their access to health care and the large inequities in prevention and screening. There isn't breast cancer screening in the north. The
Est-ce que, je m'excuse, je vais encore vous interrompre, j'aime pas.
Sorry for interrupting. I really don't like interrupting you. But I'd like to come back to this. So there's a lack of consultation. So the Métis are not at the table when decisions are taken. And then, so they have to deal with these gaps. Well, it's not really a gap. There's really isn't service. So this is what you're telling us, right?
May I answer? Chair, thank you. Absolutely. This is what we are saying, is that Métis are saying nothing for us without us. We are saying Métis needs to be at the table to represent our people in a good way, in good faith. And we do have an open, good relationship with the Government of Canada and the Government of Saskatchewan. So we are looking for opportunity for inroads so that we can address and begin the conversation and begin the distinctive base approach to healthcare for Métis citizens.
Merci.
14 secondes, mais...
Oh, c'est
30 seconds. Yes, Mr. Chair. I would have a suggestion. I believe Mrs. Chartrand didn't know what button to press for the interpretation. I didn't tell her.
We go to the next person to ask questions. For Ms. Chartrand and Mr. Tom, just in case you're not aware of it, there's a little sort of looks like a globe in the bottom near the center of your screen, and if you press that, it will allow you to choose what language you want to hear. So if you hit English, when somebody is speaking French or Inuktitut, you will hear it in English. This is so that you can listen to the questions because we have 3 languages here. I see Mr. Tom understands it. And are you with us, Ms. Chartrand? Good, great. So with that...
Can I make a comment on the question? I think I can. I understood...
If you do it very quickly. Thank you, Mr. Tom.
Well, sorry, I didn't understand the French and I didn't realize the button. But here, I just want to, just following up on the comments that were made, the answer, the inequalities, the federal government, we need to look towards the obligations of the Supreme Court decision of Daniels. And that's where all the answers lie, I think. Section 35, stuff like that comes out of Section 35, rights for Métis. And also for the Métis settlement specific, the 218 Federal Framework Agreement, which was signed with Minister Bennett of the day. Barriers, communication is huge, and the lack of communication with Métis communities. And governments like yours, the federal government, need to educate themselves on demographics of Métis people. And I believe we can all be at the table together to discuss important things such as health. And there's so many more, but the different demographics I'd like to see Ottawa and all governments be aware of different demographics is huge. And that's everything. Thank you.
Thank you, Mr. Tom. Ms. Chartrand, I see you have your hand raised. Did you want to speak?
Yes, I just wanted to also make a comment. And the question she was asking was the reason that Métis citizens, Red River Métis, they've been neglected by the Indian Act. So you look at the historic policies and you look at what's in place today, and I think they're continuing doing that. So when you look at jurisdictional battle, a perfect example would be Jordan's Principle and the programming they have. So you think about that little First Nations boy from Norway House that everyone was trying to fight for who was going to be responsible for him, and he died in Winnipeg. So you think about the Métis people that are sick and need to see the doctor, need to go for medical services. Whose jurisdiction is it? So if we work towards a trilateral agreement and we all work together for the betterment of Métis citizens, Red River Métis citizens, we don't want to play political football anymore. Thank you.
Thank you, Ms. Chartrand. We'll now go to Ms. Idlaut, who has 6 minutes.
First, I want to thank you for giving your presentation here, and welcome to the committee. I welcome the Métis. You have to be involved as you are Indigenous like us. We have benefits that you're entitled to. You too are Indigenous, and we have no question about that. We fought for ours. I understand you have to fight for yours today. Francis also mentioned Jordan's Principle. Yes, we know Jordan's Principle, and we call it Bear Witness Day, and I stood for that today at the House. I want to ask you all a question. What would you recommend to be equal and to have the same recognition as Jordan's Principle had forced the Aboriginal people to be recognized as such? What do Métis people need to be recognized legitimately and legally as Indigenous people with the rights that they should have? I would like the three of you to respond to that.
Merci, thank you for the question. I think for Métis citizens in Saskatchewan, in order to be on an equal playing field, there needs to be a commitment from our federal partners with the Government of Canada, and a commitment from our province to work together to build programs that are equitable for Métis citizens and Métis children. A lot of Métis children fall through the gaps, and then they are left, and then they experience all the social determinants of health: poverty, lack of housing, lack of education, disconnected from their family and their roots and their communities, disconnected from the land in which we thrive on. So I think it's really important that we come to the table as a partner, not only a service provider, but as a receiver. We come to the table as an equal partner. And I'd just like to turn it over to my colleague, Mr. Panahi. Yeah.
Thank you, Mr.
Go ahead.
Minister Friesen. What Métis wants, and this is what I heard from our people, they want to have non-insured health benefit. And yes, Jordan's Principle is important. We had to deal with it. I receive a lot of calls from hospitals that I have a young mom here that the baby just delivered and they are looking for a car seat. And there is no car seat for Métis citizens because they don't have access to Jordan's Principle. When they go to the social workers, the workers that provide Jordan Principle, the supports for Indigenous people, Métis can't get that. For non-insured health benefit, there was question about what this inequity is for. I'd like to share a story from Honorable Vidal's jurisdiction that a Métis cancer patient, the reason that they die sooner than other people is that a Métis cancer patient had an appointment for chemotherapy, and he was hitchhiking to get to his chemo because he wasn't able to get to the medical taxi that was available for First Nation, and he couldn't afford travel. So it was from Northwest Saskatchewan, Northern Saskatchewan. This is reality that we are seeing, and that's what we want for our citizens in Métis Nation across the homeland to have access to equitable, non-insured health benefit, which is self-determined and self-governed by Métis governments. Thank you.
Thank you. Minister Chartrand, did you want to comment?
Please. So thank you for the question. What the Métis government, Red River Métis in Manitoba want, we want ongoing funding. We're looking at A-based funding, constant funding where we don't have to go back. We don't want partial agreements. We don't want 1 or 2 year agreements. We want to make sure that the money's there and we could move forward. In fact, just for your information, we're the only Métis government that has won Supreme Court and we have a land base. We won the Supreme Court hearing in 2013. So right now we're working with the federal government to move forward. And then we referenced the Daniels decision quite a few times during the discussion today. So it's our inherent rights. We are recognized by the federal government. We want a nation-to-nation accord where we make sure that our Red River Métis citizens do not go without health care. And then we just heard Adele, he was talking about an example. So we have citizens and we have babies that are going through a bunch of heart-wrenching disabilities where the parents have to pay out of pocket, where we have to do fundraising, where we have to count on the Métis government in Manitoba because the province of Manitoba and the federal government are not listening to our pleas to make sure that we have programs and services like the Inuit, like the First Nations. We want to go back to who we are, where we come from, and we want to do programs and services where we don't have to beg for money, beg for programs and services. We're a Métis government, and we want nation-to-nation accord to work together.
Thank you. And Mr. Tom?
Yeah, I'd love to answer that. I have a kind of a chronological step of how we can work better, do better. The first, I think, is recognizing Métis people as Section 35 rights holders. I think that's key, and everything else should follow. Another thing is to identify and educate yourself on all the affiliates available, or affiliates not available, but involved in what we're talking about in the word Métis, the different demographics of our communities. Inherent rights are all Métis rights, and we all enjoy them. But when it comes to demographics of our communities and different governance models, the Métis settlements are legislated in the province of Alberta. And I think governments need to educate themselves on different affiliates so that the money gets in the hands of the proper communities. I think that the funding will follow once we assert our rights, but governments need to educate themselves that Alberta is unique to Canada, and Alberta has 8 Métis settlements, 9,500 members on a land base of 1.2 million acres, legislated, fee simple, provincial land. That will separate us, but it doesn't. I don't ever come with the attitude that we're better. I think Métis people have inherent rights, and Section 35 rights will secure those inherent rights. All we got to do is educate the government on how to split the funding, on how to, and I'll leave you with this: leave no one behind. I think that's the key. Educate yourselves on everyone and leave no one behind, because the Métis settlements have been left behind far too long. And my hope is that we'll get a day where we're heard and we're represented in that federal budget.
Thank you, Mr. Tom. I'm going to go out on a limb here and say we'll do a second round if each speaker can speak with the answer to one person and do it all in each a minute. So that's the challenge I'm giving you if you choose to take it up. Mr. Vidal, do you want to...
Can you explain that to me again, sir? I think I misunderstood.
Can you ask your question succinctly to one person?
Oh, absolutely.
Just one question.
Just one question?
Just one question, yes.
Not 5 minutes, just one question.
No, unfortunately, we're going to...
Okay, fair enough. No, I understand where you're going now, Mr. Chair. Thank you. So I won't start my clock. I'll just be succinct. Minister Friesen and Mr. Panahi, appreciate you being here. We heard from Cassidy Caron, the president of the Métis National Council. You referred to that I'm going to really summarize this. She talked about medical transportation being an issue. You shared the tragic story. I know you represent, there's 12 regions in Saskatchewan that you represent, mine being that northern. Medical transportation is a big issue. You talked about you have an existing system that you're kind of trying to build. I guess I would say, if there's one thing you could tell us, how could we improve on that? Like in the concept of non-insured health benefits, you're doing it on your own. How could that be improved so that we don't have people getting left behind, like the story you shared from a transportation perspective? Because that is a tragedy.
Merci for the question. I think to answer your question really succinctly is that the program that we initiated was through COVID, and it was sustained by COVID support funds. And it's not sustainable at this time because, of course, you know, the COVID support funds have depleted, and we've done very well to introduce that medical transportation. But as I mentioned earlier, there is a significant need, and this project demonstrated the fact that people need access to medical transportation. And as you are aware, if you're from Saskatchewan, there's no longer a public transportation system. So people have to rely on friends and family to get them to their medical appointments in an urban center. And sometimes it's 8 hours away. So that's a barrier. The geography and the transportation, the lack of public transportation is definitely a barrier. So we are looking for a more sustainable, committed funding for medical transportation. Thank you.
Thank you. Mr. McLeod.
Thank you, Mr. Chair, and thank you to everybody that presented here. I was, as a Métis person, I was getting a little nervous when you start talking about Métis citizens dying earlier than the rest of Canadians. But I think, you know, in the Northwest Territories, we're in a little bit different situation because we do have Métis Health. And, it's a good program. It's oversubscribed, but we also have every community that has compassionate travel. We heard from the NDP Métis Nation here several meetings ago when they talked about housing. Now, housing money has flowed to the national Indigenous organizations. The NIOs have received money, but they didn't get any of the housing money. Now, if the government decides to flow money to the national Indigenous organizations, which one of your organizations would get money? If you just could give us a short, quick answer.
Is that directed at a particular person?
All three.
No, just one. We only have time for one.
Okay, the Alberta guy, Lee.
All right, Mr. Tom, for you.
Okay, right now for the Métis settlements, right now we don't have a national representation. We have a president that advocates for us and the lobbyist group in Ottawa. We are not included in that funding. Any funding that comes to Alberta through our M&A region is not shared, and that's the truth. That's the truth of the matter, and we don't get it. So, as controversial as that might sound, it is what it is. I think we need to change our times, and we need to focus on listening to land-based Métis. Our settlements are communities, living, breathing, roads, schools, water, everything that comes with a small municipality that are in dire need of funding. And right now, we are underrepresented in Ottawa.
Thank you. Madame Gill, est-ce que vous avez une question?
Do you have a question? Yes. I will ask my question to Minister Friesen. We talked about inequality and the fact that to not be recognized is huge, but also the issue of territory that you spoke about, how a geography or territory makes care more difficult for the population. Thank you.
Thank you for the question. geography does play a great factor in accessing primary health care, acute health care, and ongoing treatments for health and well-being. The approach that we've taken is the same as both my Métis colleagues across the country, is that, as Ms. Chartrand has stated, leave no Métis behind, and same with Lee, he has stated, leave no Métis behind. So we would like equitable, just take medical transportation as an example, yes. We would like equitable. So if you live in the far north, you have access to medical taxi, medical transportation, ambulance to bring you to a center where your needs are going to be cared for, where your health care is going to be addressed. And we would have more prevention and screening for people so that their health needs may be undiagnosed. So we would like to prevent that from happening where people are diagnosed too late and yes, they accept the treatment, but maybe not because it's too far to travel. Mm-hmm. So we need cancer spaces, cancer lodges for community members and their family, their caregiver to come to an urban center where they can comfortably receive their treatment, live their life through their cancer journey, and be well cared for. Thank you.
Merci beaucoup. And Ms. Idlaut, if you have a question.
I have no questions at the moment. I just want to thank you for your wonderful presentation, all of you. It's become very clear that you have been left behind, and there's a lot of catch-up you have to do. If you have any final things to say to us, I would like to hear from you what's really important to you.
Merci for the question, or for the comment. Merci. We would like to be an equal partner at the table when we are discussing health care and non-insured health benefits for Métis citizens in Saskatchewan. We represent the government of Métis Nation in Saskatchewan. However, our citizens are saying this is a top priority for us. We would like to be able to sit at the table as an equal partner and not be left out of the conversation or the commitment or the financial obligations for Indigenous peoples of this country. Thank you.
Thank you very much. That brings our question period to an end. I'm sorry it was not any longer, but I'd like to thank Mr. Lee Thom for being with us. I'd like to thank Minister Chartrand and Minister Friesen and her colleague Adel Panahi for your testimony today and for answering our questions. This is an extremely important and serious subject, and we very much appreciate your input, your frankness with us today. So thank you for coming. I hope you found it worthwhile. With that, we will suspend momentarily and get ready for the next panel. Thank you very much. Going to begin our second panel, and this evening we have three witnesses, and I'll name them. Rudy Malak, who is a pharmacist at Little Current Guardian Pharmacy, who is here as an individual. We have Angela Greer, who's with us in the room, responsable des initiatives autochtones.
Responsible for Indigenous Initiatives, Counseling and Psychotherapy Association.
And finally, we have Marceline Chernich, Directrice Secteur Santé, Inu Takue Kan Uashat Makmani Utenam, who is with us virtually this afternoon. I hope I didn't mess that up too much. So I would like to welcome our three witnesses as we continue our study on non-insured health benefits. We are really looking forward to your perspective. I will ask Mr. Rudy Malak to speak first, and then the other two. You have 5 minutes, and Mr. Malak, if you are ready, you can start your presentation now.
Hello, good afternoon, and thank you for having me today. My name is Rudy Malak. I'm a pharmacist and one of the owners of 3 pharmacies on Manitoulin Island. I'm joining you today virtually from Manitoulin Island, which is the ancestral home to 6 of the Anishinaabe First Nations. Thank you for the invitation to appear before the committee and to participate in this study of administration and accessibility of Indigenous peoples to the non-insured health benefits program. I hope I can provide useful information that can be considered to improve the program, provide easier and quicker access to care for people that are in need. I'm just here to highlight some of the hardships that people go through to get the care that they need. Some of the things I'd like to discuss that delay access to care include in the pharmacy world is the prior approval processes, limits to number of eligible products, and sometimes there are permanent conditions. So things should be indefinitely approved, especially if it's a permanent condition. An example to that are ostomy supplies and having to renew it every 3 months. Another process is the special authorizations processes. Some medications have limited use paperwork involved. Examples, prescriptions written at an emergency department or chronic prescriptions for chronic conditions. Another thing that delays access to care is the wound assessment processes, which is very difficult to fill out and get approved. Example to that, we deal with acute open wounds, but the process to fill out the paperwork for non-insured for NIHB to accept it can take hours, can take weeks, can take days. So it's a very long process to get approved. And another example is just the diabetic glucose monitoring system, the flash, the sensors. It is not covered, for instance, and I'm assuming it's due to funding. But reducing complications of diabetes early will save a lot in the future. And I believe the limiting factor is funding and allocation. But I believe that a lot of money would be saved in the long run if we reduce the burden on the healthcare system. And that I think can be done through primary prevention, intervening before health effects occur. Early education about health can prevent short and long-term impacts. Continuity of care once diagnosed or discharged will reduce costs and improve outcome. Home care will improve quality to the individual and reduce hospital readmissions. And of course, removal of red tape that hinders progress and make it easier. Due to the complexity in the processes and procedures, a lot of the pharmacies are not able to serve NIHB clients because of the time needed to complete one task or because of the lack of funding to the provider. A major part of the day is spent dealing with a lot of paperwork or on the phone trying to get something approved than actually providing direct patient care. I'm sure every department and committee would like to provide the best possible care to our most vulnerable patients, but the amount of paperwork, phone calls, and bureaucracy involved makes everything difficult, time-consuming, and financially not feasible. I'm just here to express my opinion and relay information of what happens at the pharmacy level on a day-to-day basis. I'm passionate about helping people and trying to provide the best possible care and service that I possibly can. I would like people to have a dignified life. A person that is already sick or has a medical condition should not have to worry about paperwork, approval processes, coverage discrepancies, expiry of approvals, etc. All that does is just makes them lose hope in the system. And I only listed a few examples that may delay patient care. And I'll just leave the rest of the time to clarify or to answer any questions you may have. And again, thank you for the opportunity to join you today.
Thank you, Mr. Malik. We'll now go to Ms. Greer. Ms. Greer, you have 5 minutes.
Do I push the button to talk? Okay. Okay. Tutua apotsi pikani ni siksigate sitabi.
Thank you, Mr. Chair. I extend my appreciation for the invitation to participate today. My name is Angela Greer, and I'm a proud member of the Piikani First Nation of the Blackfoot Confederacy, where Alberta and Montana are situated. I'm the Indigenous Initiatives Lead for the Canadian Counseling and Psychotherapy Association, CCPA, and a mental health practitioner whose career has spanned over 25 years working with Indigenous peoples and communities. I'm here to speak to the important issue of First Nation mental health and the current barriers to care upheld by the federal government since 2015. In 2015, CCPA's Canadian Certified Counselors, CCCs, were delisted as mental health practitioners from the Non-Insured Health Benefits Program, NIHB, for First Nation and Inuit in provinces that had not yet regulated the profession of counseling. As a result, access to essential mental health services were restricted depending on province of residence. Section 9124 of the Indian Act says the federal government has jurisdictions over Indians and lands reserved for Indians, and this includes health. However, deferring to provincial regulatory authority and status to determine eligibility of mental health providers is unconstitutional. In doing so, the federal government is excluding qualified and competent providers and creating a Jordan's Principle scenario in which First Nation peoples are falling through the cracks. By restricting access to CCCs who are currently eligible providers in other federal health benefit programs, as well as in the First Nation Health Authority, which is NIHB's counterpart in British Columbia, the federal government is not only providing equitable access to mental health care for all Indigenous peoples, nor at the same standard as they are providing to non-Indigenous Canadians. This policy also discriminates against CCCs who are First Nation or Indigenous practitioners, like myself. As NIHB is the primary source of mental health funding, many cannot practice in their communities or traditional territories. The mental health needs of Indigenous peoples are higher than average due to the harms brought about by colonization, residential schools, the 60s scoop, and the reservation system. The TRC's calls to action, UNDRIP, and the National Inquiry on MMIWG all call for an increase in access to mental health supports. Early intervention is key to preventing substantial costs downstream. We know this. Related to delayed or lack of diagnosis, deterioration on wait lists, psychiatric hospitalizations, medications, dependency issues, and loss of life. Indigenous people are twice as likely to reach out for mental health supports. The mental health component of the NIHB program is seeing the fastest growth. This highlights the significant need for intervention and prevention from culturally competent Canadian certified counselors. These CCCs are an integral part of a solution to address this mental health crisis. They hold a master's degree, go through a rigorous evaluation, and adhere to a robust code of ethics, including a section on working with Indigenous peoples, communities, and contexts, among the first of its kind. In Treaty 7 alone, which is my treaty area, our First Nation communities of the Piikani,
Kainai, Siksika, Tsuut'ina, and the 3 Stoney Nakoda nations work tirelessly to combat chronically acute health environments upheld by Canada's inequitable policies. The toll on staff, communities, and clients includes pushing behind human levels into toxic levels of stress to merely survive. Surviving is not thriving. Our daily losses to the opioid war, alongside leading global suicide rates, indicate the maladaptivity experienced since contact. We have long been in pandemic states before COVID-19. Help is needed now to save lives. Mr. Chair, in the interest of equitable access to mental health services for Indigenous peoples, CCPA urges INAN to recommend that Indigenous Services Canada immediately reinstate CCCs in unregulated provinces under the NAHB program. This will add close to 1,500 providers in Alberta, Manitoba, Saskatchewan, and Newfoundland and Labrador. Thank you.
Thank you, Ms. Greer. We'll now go to Ms. Chernish. Ms. Chernish, you have 5 minutes. There we go.
Oui.
Allez-y, s'il vous plaît.
Oui, je vous remercie. Je vous remercie de nous.
Thank you, and thank you for allowing us to speak today. I'm Marceline Chernish, and I'm Innu from the Uashat Manuktanam community on the North Coast. I'm Director of Health, and I represent my organization. In the framework of my testimony, I would like to highlight some issues with regards to access to health care for members of my community, particularly for our families that are very vulnerable. The main issues that we are dealing with as members of First Nations are concentrated on access to care and service, but also access to information with regards to services offered to First Nations communities. In order to obtain care and service, the process is difficult with large delays, and this has an impact on the quality of care offered to members of the community. The bureaucracy around access to health care contributes to the deterioration of the quality of life of First Nations members. First Nations peoples have to go through 2 levels of government to obtain service. When care is not covered, the client has to make a new request with the SSNA, and then they have to start an appeals process. The appeals process is extremely complex for clients and also for healthcare professionals. There are many different steps, many different appeals, and so on. Also, as was mentioned by Mr. Malak, pharmaceutical access is a major issue for members in my community. The approval structure for medication is difficult, and this reduces access to pharmaceutical services because of the administrative burden. Contrary to the provincial service for the rest of the population, here this is an inequality. Also, we have lack of quality and service for members in our community. Mr. Malak also spoke about examples of situations lived by the population, whether it be as was already said, medical equipment, and usually for chronic conditions, and for which the client has to start onerous processes in order to receive basic equipment. And this is extremely difficult. What's more, when the client receives information, oftentimes the information is incomplete. The modalities or the the paperwork that the client has to bring is ill-explained, and I would say that healthcare professionals don't always understand themselves all the modalities around the non-insured health benefit program. Another example with regards to pharmaceutical services that is extremely constraining has to do with palliative care. When a doctor has to prescribe a medication, whether a narcotic or something else, this is given to the pharmacy. Then a palliative form has to be sent, and then it's sent from the doctor to the pharmacy, then it's sent to the NIHB program. And so there's a bureaucratic process that is extremely onerous, and these are patients at the end of life, and sometimes this delay can take up to 48 hours in order to obtain this essential medication. With regards to another aspect of the NIHB program, we have a transportation program, and we coordinate this, but the program is very rigid and is underfunded. Also, we don't have the ability to adapt the eligibility criteria to provide service that responds to the needs of the First Nations. We are not able to offer culturally safe practices. At different levels, all this aspect of cultural care it doesn't happen because the holistic aspect is not considered in eligibility criteria, whether it be for requests for escorts or other things. Thank you, Mrs. Chernish. If you're able to complete. Yes. The medical transport program is underfunded, and the shortfall needs to be absorbed by the Band Council in order to ensure adequate medical escort to the families. So when I was talking about mental health, another issue is that our traditional practices are not recognized. For example, therapy sessions, we're not able to obtain a second medical opinion or to allow the client to choose when local services are not sufficient for the patient. There are situations where First Nations members in the hospitals, and we've all witnessed this, and we have to talk about the mistrust they have with regards to the medical system. Some members of the community will refuse care, will refuse to go to medical institutions because they lack trust. Thank you. We're going to go to the question period. We'll begin with Mr. Shield. Mr. Shields, you have 6 minutes.
Appreciate the witnesses today and the information that they're sharing with us. I'll start with Mr. Malik in the sense of in the pharmacist world that you talked about. And I think you talked about connecting with people to get a lot of permissions. And I think we may have heard that from other witnesses and others today. So when you call, when you need to get approvals, are there people at the other end of the line that have any medical knowledge? Are you talking with people that understand the medical questions that you need to get approved?
Thank you for the question. I do not think so, no.
So
call a helpline. So can I just explain briefly how the process works? Mm-hmm. So the prescription comes from the doctor. We try to process it. It says special authorization required. We call basically ESI, Express Scripts, that adjudicates on behalf of NIHB. We apply for the prior approval. NIHB sends the approval to the doctor. The doctor has to fill it out properly and send it back to NIHB. Then NIHB sends back the approval with either approval or denied. So there's multiple people involved. Faxes get lost. Prescriptions, sometimes the doctors are not available anymore. The doctor has written the prescription and left already. I've had an incident yesterday. The patient came in after 1 month. The process is not complete because it went to the doctor's office. The paperwork either got lost, or they didn't know what to do with it, or the doctor wasn't available, and the patient has not started their diabetes medication for over 1 month because of that.
Thank you for running through an example like that. So, from your point of view, when you've got to go to that next level, would it make a difference if somebody had medical knowledge when you move to that next level?
That might help a little bit, yes, but at the end of the day, it has to go to the prescriber that has actually written the prescription to fill out the paperwork and say whether that patient fits the criteria for that medication.
Then what's the step that needs to happen then to make it work for you?
I believe medications that need a prior approval that should be like the provincial plan, where there's something called a limited use. The limited use is a sheet of paper where we send it directly from the pharmacy to the doctor. The doctor signs it, sends it back, and if we have that documentation, we're allowed to process it to the provincial plan. But in terms of the NIHB process, it's overly complicated, and there's 4 or 5 different people in between. The prescription to us, the pharmacist to NIHB, NIHB to the doctor back to NIHB, and then NIHB back to the pharmacy. You can imagine how many people are involved.
Medical knowledge would be my guess. So if we've heard this before, and it's got to be something that's discussed within the pharmaceutical organization. Has this been brought to you, as you know? Is it a discussion? Has it been brought forward anywhere?
Not to my knowledge, no. And as I mentioned in that opening statement, a lot of pharmacies do not know how to deal and provide service to NIHB clients because of the amount of different departments, different phone numbers. They don't know what to do. So sometimes they just say, we don't know how to do it.
And the patient gets left. Right.
And the patient's already in stress. So they leave, they're frustrated, they leave, and they don't get care.
Right. Thank you. Ms. Greer, thank you for your presentation. And since 2015 and the delisting in the last 7 years, are you familiar with any lobbying, any efforts to change this?
Yes, we've been working tirelessly within CCPA to lobby some of these changes and movements to expand the practitioners, as well as within individual First Nations. They are doing their best to lobby with NIHB currently within the clinics, the mental health clinics that's going on, to provide space for CCCs, because in the absence of those spaces, we have paraprofessionals filling professional counseling roles, because on federal reserves, we don't have regulation like the provinces do. So we're not having the unions, we're not having all of that oversight that we needed. So we're not getting the professionals that we need for the acute health environments that we have. So there is quite a bit of advocacy that continues to go on, even with First Nation psychologists are advocating for this.
What kind of response do you know you've had as you've lobbied for this change back? Have you heard any feedback of why not?
Not that I can say, sir.
You've made your organizations have made the case and continue to lobby, but there's just been
Actually,
silence?
Yeah, within NIHB, it's always from the central headquarter perspective that everything's okay, right? There's no problems, there's no wait lists. I work on the ground, I work in these communities that are have unregulated colleges, such as Alberta, and I can tell you that that is not the case. So the information that is flowing through these administration systems of NAHB and INAN are not accurately depicting what's happening on the ground. And so even the practitioners that are working in these communities, NAHB is asking for 7.5 hours a day, for example, of direct client service. That's not industry standard. That's going to burn out any practitioner. An industry standard is 4 to 5 clients a day. And yet NAHB is pushing our clinicians now in order to say, you have no wait list, you have all the therapists you need because you have 7.5 hours a day. But what people don't realize is on the ground, those clients aren't always showing up to appointments. We have transportation barriers, we have crisis communities, people who are struggling with basic needs to be able to make it to their counseling appointment, which they desperately need. So yes, there is a lot of inconsistencies throughout this bureaucracy.
Thank you. We'll now go to Mr. Baptiste. Mr. Baptiste, you have 6 minutes.
Thank you, Mr. Chair, and I'd like to thank the witnesses for their testimony so far today. I come from a First Nations community in Mi'kmaq called Eskasoni, where we have our own healthcare unit as well as our own mental health. And I know that they're hardworking folks, and they've at times come to me with very important asks about the importance of having a healthcare system that's culturally relevant, that's in the Mi'kmaq language, that is really important, that when we move forward, that we move forward in a way that's reflective of the Indigenous cultures in that area. And I'm very happy to see that in the most recent budget, 2022, that we provided $227 million over 2 years, starting in 2023, to maintain trauma-informed, culturally appropriate, Indigenous-led services to improve mental wellness and support efforts initiated through Budget 2021 to co-develop distinction-based mental health and wellness strategies. I'm wondering if the witnesses could talk to us a little bit about the importance of ensuring that the healthcare system is culturally appropriate and reflective of the various Indigenous cultures across Canada. And I think if we can start in the room, I think that would be a good starting point.
Ms. Greer?
Thank you. It's nice to see you, Jaime. Leroy Namathis say Oki. Wanted to pass that on. Yeah, I think that what you had spoke to is really the nation-to-nation relationship that we're really hoping for across our communities. We've seen the deferral of different ministries to provinces such as child welfare, such as education, and this deferral has not raised the rates of any of success in those areas. And so in similar environments such as health and mental health, because it's easier for the government to treat us as municipalities, we don't necessarily vote in these provincial governments to speak on behalf of our issues. We have First Nation governments who speak on behalf of those issues. And so they're being completely overstepped and dismissed in these discussions, and yet the provinces are taking on that responsibility. And I can tell you from, some of our perspectives that I've had, they do not share or understand the intricacies of a First Nation, the legal jurisdictional issues of a First Nation, and the needs of our First Nation. So I would, really support more of that nation-to-nation and federal, acts such as the Family Act that was recently implemented to address the children's services overrepresentation in crisis. So along those similar lines, I believe that that's going to help move things forward.
Just on following that, and please make sure that you say hello to Leroy and Namathis for me as well, and my best regards to them. Can you talk to us about any specific areas around Canada that are getting it right in terms of mental health and doing it in a way that really reflects the nation-to-nation responsibilities that we have as a government, but really that has been successful models for the rest of Canada, where we can see actually progress that is being made in a culturally appropriate and reflective way?
Yes, I'd like to give an acknowledgement to the Siksika First Nation, Siksika Health Services. The mental health clinic there is led by a Blackfoot clinical doctor, Dr. Adolfo, and who is a Blackfoot member. And her training as a clinician and as a Blackfoot member is the place that we need to be. It's providing the most competent model of delivery because you need people from that community within these senior administrative positions who are practitioners, who are not lawmakers, who actually are people on the ground who can have those relations with the province, with the federal government, in order to negotiate the best needs for the community. So I do believe that they have a great system out there. I'm sure there's a lot more. But I'm thinking about locally, and from the clinical perspective, I have never seen such an environment on a First Nation that has legally, ethically maintained the integrity needed for this type of delivery at this level of the acute health environments.
Okay, and I know I don't have a lot of time left, but I want to ask all three participants.
50 seconds, Mr. Batiste, 50 seconds.
Following question. If we were to invest money in a certain area that for Indigenous health, that we need more capacity from Indigenous healthcare workers, where do you think we would best make those investments? Just quickly, all three participants.
Mental health.
Mental health, absolutely.
Can
addiction.
Can you be specific in terms of mental health supports? I mean, there are caseworkers. What do we need?
Follow-ups. People get diagnosed, and then they don't get the follow-ups and the counseling and the cognitive behavioral therapy and the psychotherapy. It's not just medication. They need counseling and follow-ups constantly.
Okay.
Thank you very much. Thank you very much. We'll now go to Ms. Gill pour 6 minutes.
Thank you, Mr. Chair. I'd like to thank all the witnesses for being here before the committee today. I'd like to ask a few questions to Mrs. Chernish. And I'd like to highlight that she is a director of healthcare services. And for me, as for Mrs. Greer and Mrs. Malek, Mrs. Chernish, you have a very, very precious and necessary experience for the work that we're doing. Could you explain to us what would be valuable recommendations? Could you indicate to us what would be the priorities according to you? Thank you. Thank you very much. And thank you for this question. So to follow up on the mental health discussion, I would say that one of our priorities for mental health would be to invest in mental health programs for the youth. Right now, mental health programs for youth are inexistent in our community. On a provincial level, I don't think that the situation is much better. We have a huge lack of services. We see that there's a lot of distress even for children in primary school. When we talk about addiction, about consumption of substances, this is a major issue. As for priorities, we have everything that is a chronic illness, whether it be promotion, prevention, or cure, access to medical equipment, pharmaceutical services, healthcare services. All of this should be simplified. The administrative procedures for all requests for care should be simplified to create agreement protocols between different organizations, whether it be for oral health, dental services, whatever is required to simplify, ensure access to healthcare services that are culturally sensitive. I talked about this. And also to ensure funding to recognize our expertise with regards to healing, especially for services offered on the territory, and so that we can elaborate our own criteria for eligibility. So these are the points that I could bring forth right now. Thank you. I hope that you will send us your speech, and that way the committee will be able to look at your notes. During today's session, I heard the word on the ground or on a territory. Could you speak to this? This is for the three witnesses. How can we integrate services on the ground? If I understand correctly, this is part of the healing processes, but it's not really recognized, this link to the land. So what could be recommended to the committee? Thank you. Mrs. Trudich, maybe you want to begin. Yes. For us, health is a holistic thing. The First Nations vision of healthcare and health is a holistic vision. It forms a whole. A person's well-being requires the well-being of their family, their environment, their loved ones, the people that are close to them. If we look at the history and the deportation of our families, off our land, we have to reappropriate ourselves. We have to have a recognition of our traditional knowledge. And now we are trying to maximize our healing services on the land. We're offering sessions to different clienteles at different age groups, and we want patients to have the choice. They can go ahead with traditional medicine or medicine that represents us as First Nations. And what we see is that there is interest on behalf of members of the community. We're observing many things with regards to wellness when we use Nitassinan as a healing land. And I cannot ignore the fact that we also have had we've suffered a loss of our language, and earlier on we were talking about the importance of providing medical services in people's language, a maternal language, and this is obviously an issue for us. Thank you, Mrs. Gill.
Thank you. I want to thank Angela and the other people for your presentation. Very informative and very important issues that you raised. It is clear that the Métis have been treated differently than the Inuit and First Nations. I have a question for Rudy Malak. I want to understand this better as a pharmacist. When you're a pharmacist, you are well informed. It's your business. How long does it take for you to get paid by NIHB after you have billed them? How long does it take to get paid after billing them? What is the waiting time?
I believe it's 2 weeks.
Thank you. I know that as a business person, I would be worried if I wasn't getting paid on time because it would put my business at risk. Has that ever happened to you?
It definitely has, but what has happened, not the delay, it's the decline or the non-payment. If I can say a quick example, patient has an ostomy, and an ostomy is an opening in their abdomen due to they've had cancer, removal of part of their colon, let's say, and that is their only way to excrete waste out of the body. They need pouches, and they need flanges, and they need tens of different items to be able to excrete that waste out of their body. We've applied once and twice and 3 times, and months have passed. And when the patient comes, what am I going to do? Tell him I cannot give it to you? I've given them multiple supplies, and because I haven't received approvals, or the doctor hasn't filled out the document, or it's been months and months and months. And sometimes, yes, the lack of approvals sometimes may not, we don't refuse care sometimes, but sometimes we ask the patient if they can pay for it, or if they can go to their health center, if they can also advocate on their behalf, because the process is very tedious, very difficult, very time consuming. And yes, it can sometimes be, we sometimes cannot get paid if things are not done correctly and on time.
So another final question to you. Are you often paying out of your own pocket when these situations arise? Because the paperwork's not done, because the approval hasn't been done, or it's not covered by NIHB? I think you would be not the only one in the pharmacy that is sometimes paying out of your own pocket when you serve Indigenous people supposedly under the NIHB. I have heard some Inuit have been told, these we cannot pay, these are to be paid out of your pocket, and the pharmacist has refused to give us our medication because it wasn't approved.
Sometimes that does happen, yes, that is correct.
When that happens, can you illustrate to us how damaging that could be to your own business, and how much are you paying out of pocket when those situations arise?
It's very damaging to the patient. First off, because they leave, they can be frustrated, and some people can fight for their behalf and go speak to the doctor or call or go to the health center. But some other patients are vulnerable, or if they have a mental health, or if they have, let's say, schizophrenia or something of significance that they cannot fight on their behalf, they just leave and they don't get the care, and they end up in the hospital somewhere because they can't fight for themselves. Some people that have come again and again, and we ask them to also help us. So we ask them to call the doctor, call the office, call NIHB, call the health center. That's the only way to get things moving.
Thank you, Ms. Edlout. We're going to proceed very quickly to a second round. I believe Mr. Schmale is up. Mr. Schmale, you have 5 minutes.
5 minutes? Perfect. Maybe I'll start with Mr. Malik, if I could. At the beginning, and I don't think anyone brought it back up, but did you say faxes get lost?
Oh, absolutely.
Faxes. Can you tell me about that?
We send a fax
run me through that program. How does that work? First, you dust it off, and then.
Yeah, that is.
No,
yeah,
but seriously,
no,
can you run me through that? How does that work?
So like the mechanism, I don't know, but we send a fax to the NIHB for approval, and sometimes we would follow up 3 or 4 days later and ask, we sent an approval, any response? Like, we didn't get it. Well, I know I sent it, and then I have confirmation that it was sent, but they haven't received it. So we have to start the process again. And then they would fax, I believe, the document to the doctor's office. and then the doctor's office would fax it back to NIHB, and then NIHB would fax us back at the pharmacy. So yes, it can get lost. The network, the faxer's busy, whatever it is, but yes, it does happen that faxes get lost.
So the fax gets busy. That's something I haven't heard in a while. Okay, say it's 2005. Has anyone brought up the fact that we don't need to use faxes anymore? Probably more efficient to do something else?
Yes, but that is probably a system, and it has to be integrated between the departments and ESI and the doctor's offices and the NIHB call centers and the pharmacy, and yes, internet, and which system has to integrate between the other. It's a process. That's an IT issue. I don't know much about it.
That sums up government perfectly right there. Oh my goodness, that is wow. Ms. Greer, you were nodding your head on that. Do you want to? This is amazing. This really is. Do you want to add to that?
I echo his sentiments of, we're at the mercy of the professionals that are around that in this environment. Right now, I believe the federal government is exploring the racism going on in the healthcare system. Again, we're at the mercy of individuals who may not always have our best interest, but they do enjoy the funding that they receive, and may not have the cultural competency to work within our population. So we're at the mercy of these individuals. I echo Lori's comment on people who do not want to do business with NIHB. I know a lot of practitioners who say, nope, I don't get paid on time. There's too many bureaucratical errors. There's all these issues, and they won't. And so we're actually creating more barriers of wanting more the competent professionals that we need under NIHB. They're leaving. So we're left with some, I'm not saying that all of the clinicians out there, there's a diversity, of course, there's a spectrum. But really, in Canadian society, if you want to pick a therapist, you have the choice to go and try people out, because the therapeutic alliance between the client and the therapist is the most important aspect. I work with young people who tell me, it's so good to work with you now because I had to tell my white therapist what it's like on the res, right? And why do I have to keep explaining and educating to her? Whereas with myself, there is none of that. I grew up in these communities. I work in these communities. I'm from these communities. And so my work as professionals, as subject matter experts in our communities, we should be the ones that are being pulled together within within your organization of looking at this information as the subject matter experts, not the politicians.
Right. Okay. So that goes to the same thing with the faxes. If they are extremely slow about even changing the way they're doing business, to be flexible enough to make changes that are happening on the ground, it's like pushing uphill here.
Absolutely. That's why I mentioned in my speech, sir, that we're pushing past our human limits, and we carry toxic stress with us each and every generation so we can advocate and stay alive and not be, the way of our ancestors, what was done to them. So we're pushing through these bureaucratic environments that are systemic and that can be overturned by simply changing this policy.
That's unbelievable.
Thank you. Thank you very much, Mr. Schmale. We'll go to Mr. Weiler. Mr. Weiler, you have 5 minutes.
Thank you, Mr. Chair. And I'd like to thank all of our witnesses for joining today for this really important study, and really just amazing to hear some of the archaic systems that are still in place right now. But I'd like to start with asking a question through you, Mr. Chair, to Ms. Greer. My colleague, MP Batiste, had asked all three of our witnesses here just about where the federal government's investments in Indigenous healthcare can best be placed, and I think you were starting to get at some of the investments in mental health, and I just wanted to give you the opportunity to really expand on that and really just to share that with this committee.
Thank you. I was just mentioning that, in these unregulated provinces where the fiduciary responsibility the federal government has over First Nations under Section 9124, and within the Indian Act is being deferred to provinces to determine our fate. And within First Nation communities, we have tirelessly organized politically to try and create unity amongst Chiefs associations like AOTC in Alberta, or the Chiefs Association in Saskatchewan or Manitoba. These entities are the true, one of the arms that come from the community. No disrespect to AFN or any of that affiliate, but those chiefs are not elected from our communities. They're elected through regions by the chiefs of those regions. So the leadership of our communities carry the knowledge of our communities, and their technicians are people like their health directors who provide them direct information on the ground as to what's happening. So it's really important to, even in our own bureaucracies, we have to try and weed away some of that, our own political interference of that. And how do we get the stakeholder, the actual subject matter expert voice, like myself, like my supervisors and so forth, like these amazing people I'm with today, to get that direct information instead of politicizing it and keeping it removed as if it's something on a shelf when we're sitting here struggling and trying to maintain people's lives people to stay alive.
Thank you. You mentioned something else that was very troubling to hear, that just because of some of the bureaucratic troubles with NIHB, that some of your colleagues are now moving away from the NIHB program. And I'm just curious if you could speak a little bit more towards if they're leaving this program, how are their services being offered and how can people access them?
Right now, individuals who are leaving the NIHB program or shying away from it are creating sort of the bottleneck of the wait lists that will occur. And sadly, because the NIHB's statisticians here in Ottawa don't have the picture of what's going on the ground, again, it's being reflected in a way that's not accurate. So the practitioners that are, who have developed competency through working with Indigenous communities, because you don't just get competency in school, you have to have experiential competency. You have to know the community, participate in the community, be a part of our communities in order for you to say you are competent, you can work because you know our community, right? And then of course you have ethical practice standards and all that continuing education that you do to work toward those competencies. The truly most competent practitioner is the Indigenous practitioner for Indigenous people. But we have a long way to go until we can fill those spaces with full First Nation Indigenous practitioners. Until then, we work very hard with our settler populations to ensure that they're competent, and that's Indigenous-led, right? So our Indigenous Circle chapter has worked tirelessly to create the code of ethics that we implemented from their work on the ground. So I'm not sure if I was answering the question or not.
Yeah, no, absolutely. And maybe just last question to Mr. Malek.
There's about 20 seconds.
Some of these challenges that you've raised today, what responses are you getting from NIHB about some of, especially the major delays that you're experiencing to get responses?
From the people on the phone, it's out of their hands. It's out of their hands, and they don't know. They can't do anything about it. If something's not approved, it's not approved. We can try to appeal it, and then it goes to people, and then it goes to people, and then it goes to other people, and then it comes back as declined.
Thank you very much, Madame Gill. 2 minutes et demi.
2.5 minutes. Mrs. Gill. Yes, Mrs. Chernish, earlier you were ending your answer by talking about Indigenous languages. So I believe this is the first time that it's been referred to with regards to the NIHB. So could you conclude your thought, and I'll give you some time also to add what you might have forgotten or not had time to add during your testimony. Thank you, Mrs. Gill. When I was speaking about language, I was talking about everything that is holistic healing for Innu with regards to their health. Language is part, I believe sincerely, that language is part of healthcare services that have to be provided to First Nations communities. This is a means to have a culturally secure care, and it's an important component. It's important to maintain our knowledge. It's also something that could be very useful when we talk about exchanges between nations. Clearly, First Nations languages are extremely difficult to learn, but sometimes I've noticed that some professionals made efforts to enter into contact with members of our communities. And so this is important. It's an important link, the contact with the patient. And it can be an important aspect of this. Also, when we talked about care earlier on, I really liked the comment, to say that the tools being used are extremely archaic. And we are experiencing the same thing here. Another recommendation that might be implemented and that might also facilitate access to care would be to make automatically accessible for some clients, when we talk about medical escort for care in large urban centers or for third-line care. There are facilitators that could be in place to simplify all this administrative burden. Also, well, yes, we could also, when we were talking about how long it takes when people are making requests for medication, but the prescription is made out by a doctor. So this whole process of NIHB essentially is trying to contradict the prescription made by the doctor. So sometimes the process itself goes against the implementation of quality care that we have to provide to patients. So this is an aberration. Thank you. Mrs. Eadloud, 2.5 minutes.
Thank you. I have a question for Ms. Greer. I have enjoyed your presentation. It is very important that Indigenous caregivers, physicians, and health people are the best people to look after the community. We Indigenous people, I believe, if we could participate more in health issues, we could go a long ways to improving the health in our own communities by being involved. Indigenous people are very qualified when it comes to looking after life and health of the people. Thank you.
Yes, I agree. I think that I was told one time by one of my teachers that it takes highly qualified and skilled people to work with Indigenous people and to make a difference. Mm-hmm. We've seen a lot of people work in our communities, but a quality professional has to be over and above what your average Canadian knows in order to work with our populations and make a difference. So I completely agree. Thank you.
Can you give us an example or cite an example so we have a better understanding? Because we sit here at the committee and we hear things for the first time that are actually happening in the real world that we should be administering more carefully, more expediently, more professionally. We Indigenous people, what is the best way that we can get help in health delivery? What are your final things? How best to provide help in health delivery?
To take out the
I'll
middleman.
have to ask you to be succinct on that, please.
I would take out the middleman. You know, less Ottawa dollars, more dollars on the ground, more authorities to the First Nations, more authorities to the community. That's really what's going to make the change. We are the experts of our own lives. We do not need dictation from Ottawa anymore to do that. We never did. Thank you.
Thank you very much, Ms. Greer. I would like to thank you, and I would like to thank Rudy Malik, and I would like to thank Marceline Czernich. Merci d'être venu aujourd'hui.
Thank you for being here today and for having provided testimony and having answered our questions. You've contributed in a significant way on our study on the non-insured health benefit program. Thank you so much for having been here. On this note, colleagues, that's the end of our panel. A short reminder, we will be meeting on Friday at 1 p.m. Yes, I mentioned this in the beginning. I won't mention it again. So